Hello friends, this is Dr. Himanshu Bhatheja, MD Medicine, working as a consultant physician at Sri Balaji Medical Institute, New Delhi, and at my own clinic, Dr. Devaram's Doctors for You at Paschim Vihar. So today we are here for a podcast on a patient, on a case of a patient who is a 53-year-old who is diabetic with cardiovascular disease, established cardiovascular disease. So we have a 53-year-old patient who is a corporate executive diagnosed with diabetes around 6 months back. When he came for his routine checkup, he had complaints of weakness in legs, fatigability, and irritation in lower limbs. His family history was positive for hypertension and also for cardiac disease. He himself was a chronic smoker for over 30 years, but he had quit smoking 5 years ago. And since then, he has been trying to lead a healthy life. But after cessation of smoking, he had an MI 3 years back. When he came to us, on physical examination, his weight was 92 kgs, height 5 feet and 8 inches, and the BMI was 30.7, pretty much in obese category, with a blood pressure of 140 by 90 and heart rate of 92. On laboratory evaluation, sugars were a little bit uncontrolled with an A1C of 8.4%. LDL-C was 137, HDL was 37 milligram per deciliter, triglycerides borderline 156 milligram per deciliter, renal function test with an EGFR of 65 ml per minute. As of when he came to us, patient was on metformin 1 gram twice a day, telmisartan 40 mg once a day, but atovastatin 10 mg once a day, also amlodipine 5 mg once a day, and aspirin plus clopidogrel 75 mg once daily. So now we have to have a patient-centric approach for the management of such kind of patient. We have to have CV protection. We have to have microvascular protection. We have to look for the weight reduction program, reach the glycemic goal with the least possible, and I must say no hypoglycemic events. And it should be a convenient dose schedule for such kind of patients because such kind of patients are always at a risk of not taking medicines when you give them a haphazard schedule of their medicines. So the primary consideration in such cases, cardioprotection and to optimize the glycemic control for cardiovascular risks reduction and address some the weight issues. In such kind of patients, by adding SGLT2 and DPP4 in combination, benefits are bound to be received. As cardiorenal protection, it is a simple regime to follow. Single pill can be given once daily and will be sufficient enough. It is, it helps in achieving early and durable way of glycemic goals. It also helps in weight reduction and has lesser hypoglycemic episodes. So, as of for discussion, cardiovascular, as we all know, cardiovascular disease is a leading cause of morbidity and mortality in adults with type 2 diabetes, with its onset estimated to occur maybe 12 to 15 years earlier in type 2 diabetes patients than the, you know, the rest of the population. The excess risk of atherosclerotic cardiovascular disease in patients with type 2 diabetes has been estimated to be at least twice that of those with diabetes. Framingham Offspring study suggested that two-thirds of patients of diabetes have subclinical cardiovascular disease. Diabetes increases the risk of subclinical cardiovascular disease by 4.3 folds, and some clinical cardiovascular disease increases the risk of cardiovascular events by 2 folds. As we all know, the patient with diabetes vascular wall has, the advanced atherosclerotic sclerosis stage. As seen in EMPA heart study in patients with type 2 diabetes, it has shown that empagliflozin resulted in earlier and significant reduction in left ventricular mass regression as detected by the cardiac magnetic resonance imaging, and also suggests the reverse cardiac remodeling may be possible contributor to the cardioprotective effects of SGLT2 inhibitor. In 2015, the era of evolving dimensions of cardiovascular pain type 2 diabetes management began with the EMPA-REG outcome study, which demonstrated significant benefits of empagliflozin for cardiovascular mortality by around 38% in cardiovascular events as well as MACE in type 2 diabetes and CV disease. All type of CV deaths were reduced with empagliflozin. More prominent absolute benefits were observed for the heart failure related deaths and sudden deaths. The post hoc analysis of EMPA-REC demonstrated consistent cardiovascular mortality benefits irrespective of prior cardiovascular events like myocardial infarction or stroke, heart failure burden, chronic kidney disease, baseline HbA1c levels, control of multiple severe risk factors, or background use of metformin. Several mechanisms have been proposed for the cardiovascular effect, protective effect of SGLT2 inhibitors, including osmotic diuresis and natriuresis, leading to blood pressure lowering, decrease in arterial stiffness and vascular resistance, decrease in weight, also decrease in uric acid and oxidative stress. It has also been reported that SGLT2 inhibitors promote severe cardiac remodeling, also reduces the left ventricular wall stress and mass, and somehow reduces the blood pressure and arterial stiffness. The EMPA heart study, CardioLink 6 study, demonstrated that empagliflozin could produce early reverse cardiac remodeling in type 2 diabetes and stable coronary artery disease. And Carmelina and Carolina trials, linagliptin has also demonstrated cardiovascular and renal safety of linagliptin versus the placebo or active comparators when added to standard care of patients in type 2 diabetes who are at high risk of vascular complications. As of now, there are many SGLT2 and DP4 combinations available, but EMPA and LIMA is available as the first line class treatment in SGLT2 and DPP4 combination group of drugs. At week 24, EMPA-LINA at a combination of 25 and 5 mg showed statistical significance of HbA1c reduction as an add-on therapy to metformin. HbA1c decrement by EMPA-LINA combination of 25 and 5 mg has demonstrated 1.81% HbA1c reduction at an HbA1c baseline of 8.5% at 24 weeks. The combination offers a suitable component in the strategy to achieve the target HbA1c without hypoglycemia, without any weight gain in patients with baseline HbA1c levels, together with the cardioprotective effects in such patients who are diabetic and who already has an established cardiovascular disease, like in our patient who had an MI just 3 years back, who is already a known case of diabetes past 6 months. So I must say that EMPA and LINA is a good combination, which is helpful in such patients who have higher weight, who have kidney involvement, who have diabetes, who have cardiac issues. It helps in both diabetic way and cardiovascular way. There are many more combinations coming in the form of dapagliflozin and vildagliptin, but I must say that EMPA and Lina combination is going to be there, sky high with its efficacy in reduction of cardiovascular risk and the diabetes control without any hypoglycemic events. Thank you.